Hello class, Dr. Darty here. I thought that the easiest way to cover any additional content and questions for Shoulder 3 would be to just do a voice over PowerPoint. This is not mandatory, but I will post this on the portal and you can watch it so that it may help answer some questions on this content. But this one is not mandatory. Most of the information is on the slides. I'll just speak to some of it. So again, there's two types of shoulder impingement that I want you guys to know. There's mechanical, which is also called external impingement, and there's internal impingement. So external impingement is what you normally think about when you think about shoulder impingement. It's anything that causes compression or abrasion in the subacromial space. So there's a lot of normal structures in there that you could potentially impinge. The rotator cuff tendons, pretty much any of them, but more likely supra, infra, long head of the biceps, that sort of thing. Subacromial bursa, coracohumeral ligament, etc. These patients demonstrate the classic painful arc, and the classic painful arc is when they report pain throughout the one of the elevation planes, or maybe all of them, whether it's abduction, scaption, or flexion. It doesn't make a difference. The point is that they have pain that's initiated somewhere in the 60 to 120 degree range that dissipates after that, and they may or may not have pain at the very end range of elevation. Okay, but they have pain somewhere in this mid range between 60 and 120, and only there. And so the concept is that's when there's the least amount of space between the humeral head, greater tuberosity, lesser tuberosity, whatever is impinging into the subacromial space, or whatever bony margins are impinging into it. That's where the least amount of space is, depending on what plane you're moving. And so if you elevate the arm right at about 60 degrees, believe it or not, that's the smallest amount of subacromial space you have, because after about 60 degrees, the scapula does begin to upwardly rotate, and it helps create or maintain the space after that point. But 60 and below is where it's mainly humerus motion. So it's right at about 60 degrees, there's the greatest risk. Research shows anything below 90 actually has the greatest risk, but if you were to pick one, it'd be closer to the 60-degree range. So that's usually where that painful arc is initiated. Internal impingement is where you get pinching below the subacromial space, in the space between the humeral head and the glenoid. So it's like pinching the rotator cuff between that little crack between the glenoid and the humeral head, which I'll show you in the next slide. This is going to be a lot more common in overhead athletes, somebody who gets into this overhead externally rotated position in which they function. So they wind up those rotator cuff tendons and they draw them into that space where they are impinged or pinched. And the greater risk of internal impingement is above 90 degrees. The greater risk of external impingement is below 90 degrees. So this slide just, I think, will kind of help highlight the, let me get the laser pointer going here. So, or the pen. So what I'm talking about is right in here, right in that space in that triangle. So when you elevate the arm and externally rotate, this tendon is drawn inward in this manner, and it gets shoulder impingement syndrome. Some contact is normal. Bursas are fluid-filled sacs that obviously cushion one structure from the other, so a little bit of touching is normal. That's not really an issue, but what happens is we have too much contact for one reason or the other. Several different causes. It could just be excessive exposure, such as somebody who repetitively impinges on those structures. So a little bit of rubbing's fine, but when you do it time and time and time again, such as an overhead athlete or some sort of job occupation like a construction worker, carpenter, somebody who, let's say, is hammering overhead, that could start to cause this. So anyway, other causes include structure, bony causes. If there's an instability or the laxity, you can get too much translation of the humeral head, which can cause approximation of the bony surfaces, pinching the soft tissue in between. If the capsule was held abnormally tight, it could limit the normal osteokinematic motion and arthrokinematic motion. So instead of, let's say, the humeral head gliding inferiorly when you elevate the arm, it doesn't drop downward or inferiorly, so it actually doesn't create more space between it and the acromion, and so you end up pinching. Could be due to muscle imbalance, things could be tight and or weak, could be just postural causes. Those are functional causes. Those are things you can pretty much fix right away and immediately begin working on. So that's kind of nice. If you slouch, you cause more impingement. Impaired ability to move the scapula, and then extrinsic factors such as nerve, trauma, and disease. Here's a good slide showing you the orientation of some structures and actually how little space there is in here. You can't really visualize the bursa well, but you can see is the margin there of this of the infraspinatus tendon, and realize that, I mean, it's hard to see these shadows, but we're talking it's this whole structure here is all infra. Supra, you can see the muscle belly up above the spine of the scapula tucking out and that tendon coming out up here. So when somebody impinges their shoulder, they normally report pain somewhere in that 60 to 120 degree arc with active motion, and they'll report this general achiness out here in the lateral brachial region. All right, so the side of the arm, which may seem somewhat off because the pinching's occurring here. You know, if you look at the slide to the right, the pinching's occurring here, subacromial space. Something's getting pinched between the acromion and humeral head. So it's in this space, or you could be pinching a structure up against the ligamentous tissues. So pinching somewhere up here, yet their pain is all the way down here. Why is that? Well, that's where the referral pattern is for this area. So we have lots of areas in the body in which when you pinch them, you feel pain elsewhere. Think about the dermatomes of the spine. You know, you pinch a nerve root in the lumbar spine, yet the patient may have pain just on the lateral outside of their foot, right? So it totally depends on where that referral pattern is for that. But the most common referral area for impingement is the side of the arm, not the actual shoulder joint itself. They tend to have palpable tenderness of whatever is being impinged. They tend to have muscular imbalance, and due to that muscular imbalance, they have impaired motion of their scapula or scapular dyskinesis. All right, here's some pictures of structural causes of different shapes of the acromion. You can see that the white outline is basically the acromion now. We could have different types like the red acromion, in which it actually is shorter and flatter. So it's got more of a curve to it down here. And then the blue outline would be more of that hooked acromion. All right, so more of that hooked acromion. So you can see that both the red and the blue would encroach into this space in here. They both encroach in here, so they could be a cause of structural impingement. The rotator cuff itself could get abnormally thick, such in the case of a tendinosis. You often have thickening of the tendon. You could have an issue with the humerus. You could have bone spurs off the acromion, all that good stuff. Anything that would occupy. Let's talk about the postural impingement. We've all done this test of this man over here on the right, in which you slouch, raise your arm into flexion is the easiest to see, and then notice that if you put your arm down, sit up nice and tall in good posture, and repeat this forward flexion, you will have increased range of motion, and if you had any symptoms before, they will likely be decreased due to that. So don't underestimate the impact of correcting somebody's posture and giving them postural exercises. Extrinsic factors could be nerve pathology, which we hit on more in shoulder 2, causing an actual palsy, which we see here with these altered movement patterns. If you look at this slide here on the right, we see that this level of scapular winging is severe. This person likely has a palsy of the long thoracic nerve, and their serratus anterior is completely impaired, and that's why we're seeing this severity of winging. The other causes of impingement, such as instability or laxity, well, if we have excessive translation of the humeral head, so the humeral head does not sit where it should in the glenoid, let's say it migrates too far superiorly, it's going to cause compression up of those tissues up into the acromion, the undersurface of the acromion. So you could have capsule laxity really in any direction, anterior, posterior, or inferior, and ligamentous laxity. All right, muscle imbalance. So it could be as simple as weakness. So rotator cuff, external rotators. Weakness of that is actually linked to decreased space between the acromion and the humeral head. That's all that means, is that when they looked via imaging at the subacromial space, and they tested people's rotator cuff strength, they found that people who are weak there have less space. It's kind of something we already knew. We already theoretically treated for this, but it's nice to see it proven in the research. So we know that the external rotators really help seat the humeral head more than they help depress it. They don't so much pull it down, but if you look at the line of pull of those structures, you'll see that they're more about pushing into the glenoid. Okay? All right, so they seat the humeral head into the glenoid and maintain that position in that space. Scapulothoracic muscle that we're really concerned about focusing on strengthening and working on is going to be the lower and the mid traps and serratus anterior, primarily because of their influence on the scapula in which they fire and the motions they actually prevent. Okay, so if the lower and mid trap fire appropriately, they keep the scapula externally rotated. They allow it to normally upwardly rotate without winging or without tipping anteriorly excessively, which is a pathological position of the scapula. The other imbalances we look for are not only weakness but also tightness. So pec minor and major are tight, particularly pec minor attaching to the coracoid can tilt the whole scapula anteriorly. Shoulder internal rotators can also cause that and also pull the whole scapula into internal rotation. So don't just think of its influence on the humerus pulling that internally, but it would also pull the scapula into internal rotation as well, which is also very bad. Okay, instability. We're going to talk about two different types of instability. There's TUBS and ambry, and sometimes ambry is written like this, or it's written with another I here. TUBS stands for traumatic unilateral Bankart injury requiring surgery. So this is somebody who we say is torn loose. So TUBS, torn loose, means there's a traumatic event that caused them instability and it's in one direction. All right. Ambry is somebody who was born loose. So this is somebody who has laxity on both sides. So it's atraumatic, multiaxial or multidirectional, bilateral, requiring, if surgery is indicated, it requires, that's the R, requires an inferior interval shift, which means they particularly tighten up the inferior aspect of the capsule. So that's what those stand for. All right, so this is somebody who was born loose. They're loose everywhere. They have multidirectional instabilities. TUBS is somebody who had a traumatic event and they tend to just have laxity in one direction. This top picture is a good sign of the sulcus sign. You can see the divot that the arrow is pointing to up here. And down below we actually see a true load and shift test. In this case they're loading posteriorly, and then here's the same patient who's being loaded anteriorly or shifted anteriorly, excuse me. So we see the little asterisk showing you that, all right, that's the glenoid and part of the acromion, the margin right there. So look how posterior they go. And then here's the same patient, now they're lying supine. Look how anteriorly they shift. So that is somebody who has ambry. That's multiaxial. Somebody who had TUBS, a Bankart is an inferior dislocation, right? And so it's anterior and inferior, somewhere in that part of the glenoid and labrum they dislocated. So they're going to be likely to have this sulcus sign here. All right, complications of an anterior dislocation, there is a bunch. Axillary nerve injury, so they could have atrophy and wasting of muscles like their deltoid. The other vascular component primarily would be the humeral circumflex arteries could be compromised. The instability afterwards, so after you dislocate, you're definitely lax to some degree. Okay, that's why immobilization is so necessary afterwards, because once you tear something like that loose and dislocate, it's going to stay loose. All right, so you got to get control using surrounding musculature, get dynamic balance of that, but the capsule is pretty much loose unless there's surgical intervention. Obviously, if you take the humerus that far away from the glenoid or in that far in the anterior direction, you could obviously tear a rotator cuff or your long head of the biceps. Okay, instability can take the form of traumatic instabilities as well, right? So we talked about the tubs being the torn loose, and that kind of fits right in under here as a Bankart lesion would be an example of a tubs injury. Excuse my circle there. So a Bankart lesion is a lesion in which, usually after a dislocation anteriorly, you tear part of the anterior inferior labrum. Okay, so right in this area. Oh, too far. So anywhere from kind of like normally about like 3 o'clock, anywhere down to about 6 or 7 o'clock. That's usually Bankart. And you can have Bankart in which you tear the labrum, or you can have a bony Bankart in which you tear the labrum and also affect some of the bony glenoid as well. So one that affects the inner part too. A Hill-Sachs lesion is what we see a picture of here on the left. So if you trace this line out, this should be a continuous convexity out here. It should look like the side medially, but you can see more on the outside that we see this divot fracture, and that's what a Hill-Sachs lesion is. It's really a compression fracture because the glenoid is much firmer and harder and resilient as compared to the humeral head, which is soft by comparison. So what happens is when they contact one another with a dislocation, and it's usually that superior posterior aspect of the humeral head from an anterior dislocation, the back part of it catches the glenoid, and you get this divot compression fracture, which is a Hill-Sachs lesion. And then a SLAP lesion stands for superior labrum. That's the part that's involved. So superior labrum, see this black outline here. And then they present with right in that box there, they present with a anterior and posterior instability. So it's superior labrum, anterior to posterior, anterior and posterior, meaning that there's a SLAP lesion up here, so a superior labrum tear, and they can have so the mechanism of injury is usually a traumatic event. So it's compressive force with a subluxation, all right? And when it subluxes, it goes and tears that part of the labrum, and we can see several different types of SLAP lesions here. The first one kind of showing tearing on the periphery. The second one showing this sort of avulsion of the biceps tendon distally, or excuse me, proximally. And then we can see on the third picture, we actually have some pulling back of the labrum and some tearing of that part. And then we can see that in the fourth one, we actually have a much larger grade avulsion of the labrum, but it's continuous with the tendon. So it's like the tendon actually pulled part of the labrum away. All right, so that's a SLAP lesion. And then we can also see here a picture of a Bankart lesion in which the injury is in the lower labrum, lower part of the labrum. So SLAP lesion could also be caused to a repetitive microtrauma, such as a baseball pitcher or an overhead athlete who functions in a lot of external rotation because they repetitively peel back by winding up the long head of the biceps. They repetitively pull on the labrum, because don't forget the labrum is really just a continuation of the long head of the biceps. So that repetitive pulling then causes eventual degeneration and pathology of the labrum itself. So anyway, you really want more than one special test to be positive. You're going to learn several as you get to E1, but you really want more than one to be positive, okay? So kind of like the more the better, basically. And passive range of motion accessory, what findings would you expect? Well, think about it. If the labrum was significantly torn enough to be displaced, what would your end feel be, which is your quality for passive range of motion accessory? Well, you would think potentially your quality would be a displaced meniscus end feel. You would feel that springy rebound. If it was a Bankart lesion, you would maybe think you would get that in the inferior direction, and if it was a SLAP, you're thinking more in the anterior and or posterior direction. That would be for a significant tear. You could also get a capsule laxity end feel or a ligamentous laxity end feel, depending on what you actually felt, because after this tearing has occurred, they tend to have a looseness as an impairment afterwards, or laxity. Here's a Hill-Sachs lesion. So again, this is like that anterior dislocation. So you compress if you look at this top picture, you can see that as it dislocates, as the humeral head dislocates from the glenoid, in the bottom picture it's seated normally, but if it goes excessively anteriorly, what we see is right here, we see that the rim of the glenoid actually impacts the humeral head and causes this divot fracture. All right? And that's what you see if you were to relocate it. You see this impression that's left. All right? So anyway, this is considered a type of compressive fracture, and the humeral head is soft, and the glenoid rim is really a lot firmer by comparison, and so that's what causes the fracture in that posterior lateral aspect. All right, the Bankart lesion, mechanism of injury, it's usually a traumatic subluxation or a traumatic dislocation, and what that causes is an avulsion of that anterior inferior labrum from the glenoid rim, but if the glenoid rim is involved, then we call it a bony Bankart. So just a Bankart lesion by itself just implies soft tissue is involved. All right, and same thing for the accessory findings. Could get the displaced meniscus end feel. You could have laxities. In this case, you would expect it to be more definitively in the inferior direction, but you could also have it in the anterior direction. You know, it just depends on where the actual tear took place. So if the tear was, more at like the 4 o'clock position, you may also get a displaced meniscus end feel, and or potentially capsule laxity when you go in the anterior direction too. So the special test for Bankart, well, the sulcus sign would probably be positive. There are some other special tests we will learn for the rotator cuff, but I'm asking you to recall ones you have already learned to see if you can think of a special test for that. All right, management. Non-operative, conservative management can work. I have definitely had a patient, one patient in particular, in which I did a poster on, and Dr. Chaconis and I presented this patient at AOMPT as a poster presentation, in which they had all 3 lesions. They had a Bankart, they had a Hill-Sachs lesion, and they had a SLAP lesion, all from a traumatic anterior dislocation. So you would think, well, that's it. This patient definitively needs surgery if they've had that much trauma to their labrum. Their joint's going to be too loose, and they're going to have the other meniscal displacement or labral displacement signs of the clicking, the popping, the locking, significant pain. But we were able to manage him conservatively with rehab. We actually got him almost this exact same splint here. So this is an abduction splint. You really want that. All right, you want that forearm rotation, you want the humeral rotation in neutral to slight external rotation. All right, they've shown through MRI studies that this puts the least amount of pressure on the labrum. That makes sense. We know if we're in too much external rotation, it would glide the humeral head anteriorly. That would put too much pressure on that part of the labrum. If we were in too much internal rotation, like a traditional sling and a traditional splint for the for the arm and shoulder, in which the arm's just held like in a guarded position against the body. That's too much internal rotation. It's going to put too much pressure on the posterior part of the labrum. So this is the best type of splint you want. There's a nice squeeze ball there so they can still work their hand and wrist. There's no reason why they should not. You do have to be careful of how much you allow them to move their elbow actively, because if it was a slap lesion, then the long head of the biceps is involved in some level, even if it's indirectly involved by pulling on that long head of the biceps tendon, such as through a contraction or through overstretching. You are pulling on the traumatized and pathologically involved labrum. All right, so these are some general principles that you can kind of read for yourself, but the thing is, don't wait on scapular firing and scapular thorax. Don't wait on that. Get started on that immediately. There's no reason why they can't move their wrist around, why they can't do scapular retraction and depression, why they can't work on their posture, why they can't do gentle stretches as appropriate for the wrist and their fingers. It doesn't mean they just hang out in the sling when they're supposed to be in the sling all the time for that 4 to 6 week window approximately. It doesn't mean they do nothing during that time. You should give them a supportive treatment to make sure they don't have as much losses as it would normally. And if you start working on the scapula, you're not changing the position of the glenohumeral joint. If you're not moving the humerus, you're moving the whole thing as a unit. So this will give them a head start on thorax, and I've seen good results with this empirically in the clinic. All right, so how does a physician manage it? Well, they go in and do an arthroscopic repair. You don't see as many open procedures anymore where they do a large open wound. They tend to go in arthroscopically. If you look down at these slides at the bottom, we can see the rim of the glenoid, and we can see the normal labrum, which adds a significant amount of depth to the glenoid. Okay, about a third of the depth of the glenoid fossa is made up of that labrum. So it means if we're talking about a concave surface like a cup, it's a pretty shallow cup as a bony glenoid. When we add the labrum, we get about a third of the depth of that cup from that. So it's a better cup, so it holds the humeral head in place a little better. See here on the arthroscopy view on the right, we can see this detachment of the labrum and how there's space. See the space in there, the black space, and here about how this is pulled away from the glenoid. So often what they do is they put these anchors in. They'll suture this together if it's torn in and of itself, and then they got to anchor it down to the glenoid, and they'll use these bony screws, these suture anchors. So once they suture it down, then they anchor it in. Those of you familiar with construction, they look a lot like concrete screws. That you would use if you were drilling something down into your garage floor, let's say. So anyway, let's talk about the two different Bankart repairs, arthroscopic and open, as far as the wounds you're left with. Now, top is an open procedure. There would have probably had to have been a significant amount of trauma to other things as well as a labrum for them to justify going in like this, and maybe they have massive rotator cuff tears as well, and they really needed to go in with this approach. But you can look at the size of that scar margin, and then look at it here with an arthroscope. There's usually 3 ports. Usually here's 1, here's 2, and then the other one's behind it. And so obviously you're going to have less implications for scar tissue limiting motion with this arthroscopic repair. It's way less invasive than the top one, the open repair. What you do have to watch for is that these portholes, when they fill in with scar tissue, remember that that port went all the way down into the joint. So it went through the muscles, it went through the skin, it went through the fascia, it went through both layers of the capsule, it went through any bursas potentially. They try to minimize how many things they have to poke through. But the point is, those scar tissue anchors kind of go all the way down. So you still have to make sure that these are mobile, and do some myofascial release techniques, myofascial manipulation. Make sure that they have good movement there of that scar tissue and they're not bound down to those underlying layers. All right, so management post-op is really driven by the size and position of the lesion, right? It really depends on how bad it is and where it is. That's going to determine what you can and cannot do. But overall, you're trying to get stability of the shoulder back. But you got to protect the repair. You want to minimize the effects of immobilization. That's what I'm talking about. This active range of motion of surrounding joints and structures that you're allowed to move. The scapula, the wrist, the elbow, as long as it's not really a slap lesion, they may have to limit their elbow usage. Restore range of motion. Primarily, you got to get that back. Restore scapular strength. Restore posterior cuff strength. Remember that external rotation strength, the strength of the posterior rotator cuff, meaning infraspinatus, supraspinatus, teres minor, is really going to help seat the humeral head and the glenoid, and that's going to add a lot of the stability for these patients. So they have to have good external rotation strength via strengthening their posterior cuff muscles. And then don't forget, you always got to keep in mind function. What is their goal? What are their roles they need to do for work? So on and so forth. Okay, here we see it again. Tight joint capsule again. Same pattern where I left this in here as a review. So the capsular pattern, again, we're always looking at these two steps, really broken into to three sets. So we have active range of motion, passive range of motion, classical, and passive range of motion accessory. When we're looking at the shoulder joint, we have a pattern of external rotation is limited greater than abduction, which is limited greater than internal rotation. And don't forget, this abduction is actually scaption, right? It's scaption. It's glenohumeral abduction, so it's elevation in the scapular plane. And so that's what we see is this limitation actively. We also see the same limitation passively. So classical range of motion is limited in the exact same pattern. The end feel for both classical and accessory should be a tight capsule end feel. And then we have to match up these arthrokinematic motions to the osteokinematic motions above. All right, so an anterior glide is the component motion for external rotation, so that's the most limited. An inferior glide is a component motion for shoulder elevation and scaption or abduction, right? That's the main glide. And a posterior glide is the main arthrokinematic for internal rotation. So we're matching those up. So that's what you would find. Accessory-wise, it would match up to your osteokinematic motion, which you measured in classical as well as actively. Okay, so here's food for thought. What about an adhesion? What if you just have scar tissue? Okay, you have scar tissue and you feel that scar tissue in the posterior direction. What would the findings be for these steps? Take a moment and think about that and answer. Look at these steps and then switch the findings from a tight joint capsule to an adhesion. Tight joint capsule to an adhesion. Okay, so let's talk about the posterior glide would be limited. So they wouldn't have a pattern of restriction. They just at least have this restriction in one direction. So you would see them limited in internal rotation potentially. You could also see them limited in an elevation that requires internal rotation, such as flexion. They're in more internal rotation for flexion than they are for abduction, so that could also be limited. For passive range motion classical, same thing. Primarily, it's going to be internal rotation would be limited. But other things that require a posterior glide as well. So go through your E1 manual, look at the component motions, match the ones up that are the component motions for the posterior glide, and those are all motions that could potentially be limited both actively and passively. Your end feel would change though. Your end feel would be an adhesion end feel, and pain would purely depend on the level of reactivity of that tissue. All right, scapular dyskinesis. What is scapular dyskinesis? Well, it's any altered scapular motion. So altered scapular movement. It exists in the presence of shoulder injury. So we see it and it correlates to shoulder injuries, but it's not directly linked to pain. People can have it in pain-free conditions, and this can be managed effectively through conservative management. You've already learned from some special tests for scapular dyskinesis, and we're going to hit on those again. All right, so what's the dynamic pattern of pathology, meaning what is the pathological pattern of the scapula? Well, they tend to lose full upward rotation And normally, if you're in full flexion, full shoulder flexion, that inferior angle of your scapula should come to the midline of the body, basically the axillary line. So if you basically draw a straight long line looking at somebody's armpit, right, the kind of midline line of the body looking at the armpit or the axilla, you should see that the inferior angle comes all the way out to that line. Also, in a pathological condition, you see excessive scapular internal rotation, and this is usually due to decreased activation of serratus anterior. So they're tilted in the internal rotation position too much. So you may see the medial border of the scapula looks like it's prominent off of the thorax, like it's more posterior. You also see excessive scapular anterior tilt, and that's actually the biggest one research-wise is the anterior tipping or tilting seems to be the most pathological, but these are all bad. This is a pattern we see when there's issues. There is a force couple. You know, the shoulder relies on muscular stability more than any other joint, right? And so to have that amount of mobility, you obviously don't have as much inert stability, right? You don't have a lot of bony stability, you don't have a lot of ligamentous stability, don't have a ton of capsular stability. You need muscular stability. Okay, so you have these force couples, and you can read that for yourself, but realize that things that prevent superior migration of the humeral head, like subscap, infraspinatus, teres minor, there's that posterior rotator cuff strength again. So the posterior cuff muscles need to be strong because they help prevent superior migration. Remember, it's not so much the depression of the humeral head, which is what people used to think the rotator cuff was doing. It's more about seating and preventing the humeral head from migrating upward. All right, here we see some Capangyi slides from a Capangyi textbook in which they're showing you sort of the force couples of these different muscles. So, excuse me, you should be able to pick out all these muscles. Number 1 representing the supraspinatus, 3 representing the infra, 4 representing the teres minor. So when they fire, those directions show the direction they're pulling, and also the size of the arrow is meant to represent the magnitude that they would pull with, right? So the larger the arrow, the more force they exert. So you can see with these overhead views how this is a force couple and how all these would draw in and compress the humeral head into the glenoid and the labrum to add some stability. All right, sick scapula is a term you'll see. I address it here because this is a syndrome. All right, and they describe a syndrome by saying there's these 4 features of it. So for shorthand, they just say it's a sick scapula, and every letter stands for something. All right, so this is just a syndrome. This is very general. This is not a tissue-specific impairment, but this is out there a lot in the clinical world. So it's characterized by, first, S standing for scapular malposition, means they have a resting poor position of their scapula, which you have learned to evaluate with the lateral slide test in lab. They have inferior border prominence, which means they're tipped anteriorly too much. The scapula is, and you could see that through your structural inspection. They have coracoid pain. They report pain on the front of their shoulder over their coracoid process area. And they have kinesis, or abnormal movement of the scapula. That's the K. Here is your lateral slide test, which we've already done in lab. 3 positions. You will see more positions described in McGee, but you only need to do 3 positions because those are the ones that hold up the best in the literature. So 3 positions are at rest, hands on the hips, and 90 degrees abduction. So at rest is kind of like 0 degrees abduction. Hands on the hips is about 45 degrees, and then you go full 90. And in any position, if you see greater than 1.5 centimeters, and I just round up to 2 because I like to make things pretty clear cut, and I don't want to be tripped up if I measure 1.6 centimeters, but then just to be sure I remeasure and I get 1.4 centimeters. To me, that's not that significant of a difference, but the literature has showed anything greater than 1.5. But if somebody has a severe problem, you would expect there to be more of a difference. All right. Scapular motion test. So one way you can tease out scapular dyskinesis is by doing repetitive motion testing. And they used to do a whole bunch of motions. They now found that all you really need to do is flexion or abduction, either one of those, or you can do them both separately. I tend to just like flexion because I think it teases it out quicker. So you start with 5 to 10 reps, and I like to add a small weight to them. I actually do that first. If I don't see it with just the weight of their arm, after even a few repetitions, I'll hand them a small weight. Nothing more than 5 pounds, and for most people, just a few pounds. 2 or 3 pounds tends to do it, tends to bring it out. And you're looking for a consistent pattern. Like you can see on both of these patients, on the left you see medial border prominence when she's elevating her arm, and over here you see this guy is doing abduction, and you see not so much the whole medial border, but you see that the inferior angle is much more prominent here where that dark shadow is. So that's showing that they're doing anterior tipping. And look at their other side. Their arms are even in both of these pictures. I know you can't see the woman's arms on the left because they're straight forward, but the other scapula is in the correct position. These left sides are the pathological ones. And you're looking for a consistent pattern that happens over and over again. So scapular motion tests also. There's symptom altering tests, right? You learn the scapular assistance test, and you're looking for a 2-point change in the pain rating. That is a good predictor of conservative management. If they have a positive test, you know that if you get better functioning of your upward rotators of the scapula, such as serratus anterior, such as proper levator scap, such as proper low trap firing. If you get this balance back, then you know that they can have that effect naturally on their own. So your hands can be replaced by the normal functioning of the muscles, and then you know that you're probably going to at least decrease their pain 2 points. So it helps with goal setting and other things. But the sky's the limit. And this is actually Dr. Kibler there in the lab coat doing that test. Okay, here are them. They're showing a force gauge here on the right of how they would measure that Job's position. And so actually they used an assistant when they were studying this in the research. So one person held the scapula down and in proper position, and then the other person added the force gauge. So remember, there's basically 2 tests that are very similar. The retraction and the reposition. They came up with the retraction test first, in which you put them in full retraction. You check this and see if they have a significant change in their pain or their strength. The reposition test is much less. It's just a cue towards retracting. So you're just barely repositioning the scapula, more so a cue than actively thinking of moving it. So you're just resting lightly the weight of your arm. And you're really just doing that to cue those muscles to fire better, and you're looking for the exact same outcome, significant decrease in pain and or strength. Okay, so B is actually tends to be the position most people do that scapular reposition in, because they just do that cue. Usually retraction may take both hands, such as in this picture, to really hold that scapula in that position. You don't really need to know this, but just FYI, the reason why they have 2 tests that are so similar is they used to just do the scapular retraction test, but then they found that when it came to strength, that people were actually stronger with the force gauge if you just did a little bit of cueing rather than pinning the scapula back in full retraction. So they found less force got a stronger strength change, which is actually also encouraging for